Hi, good morning, everybody. This is Sabrine Clinton, Maternal Fetal Medicine Fellow, first year. Just I want to make sure that my slide, you can see my slide so far.
Yes, Sabrine, we can. Good morning.
Good morning. Thank you. So thank you for attending our grand round today. And actually, before I start my grand round, a special thanks for Dr. Hsia, and he's the consultant hematology and helped me a lot in preparing this presentation, as he provided me with the guidelines and answer all that I need inquiries and questions to prepare my round. And also a special thanks to Dr. Eastabrook and reviewing and helping me for preparing for this round. So about today round, hemostasis, thrombosis, and wound healing are impossible without little plate, or called Clot-Cell, which means platelet. I will start my round by a rare case that we deal with her during our MFM practice. So we have a 38-year-old lady, and she was seen in preconception clinic. And CG had a long-standing history of ITP, and she was unresponsive to medical therapy, 100 milligrams of prednisone, and her platelet count at that time was 91. She underwent splenectomy at the age of 10 years old, and from that time she had annual vaccination, and her platelet count ranged between 25 to 35 and never more than that. And she occasionally have gingival bleeding, episode of epistaxis, some menorrhagia, but did not have any other significant bleeding or severe bleeding. Regarding her past medical history and past surgical history, she had ITP, splenectomy, lumpectomy for benign breast lump, and no anesthesia complication, and never she had a blood transfusion. Gynecological history, she had a regular cycle, and currently when we saw her, she was on oral contraceptive pills and never had pap smear, as she has not yet been sexually active, just recently getting married when we saw her in preconception clinic. Drugs and allergies, she was on prenatal vitamins, and she is known to have drug allergies. Family history, there is no significant family history for any bleeding disorder, and her background is German Mennonite, and her partner is Irish and Welsh. Social history, she was emergency department nurse, and her partner worked in cybersecurity. She had never smoked, used alcohol, cannabis, or other recreation drugs. There is no social relationship concerns. And physical exam, because it was phone clinic, so she told us that her height, it was 5 feet and 8 inches tall, weight 190 pounds, and body mass index 29. And investigation that we reviewed, it was done in July, and showed that her platelet at the time, it was 27. So in that preconception clinic, we focus on the management of the pregnancy in the context of ITP. So we discussed with her that any autoimmune disease may increase the risk of IUGR, placenta insufficiency, and can also cause transient fetal thrombocytopenia. And we told her that we will do antenatal, when she get pregnant, antenatal follow-up, when the ultrasound growth, and frequent CBC. And also regarding, we discussed about time, mode of delivery, and operative vaginal delivery, and level of the platelet count related to delivering, and anesthesia, possibility of platelet transfusion in acute situation, and treatment option that would be appropriate during pregnancy and safe. So after a couple of months, she presented in our antenatal clinic as her first antenatal visit. At that time, she is a 39-year-old primary. Gestational age was 12 weeks plus 1 day, with a due date of 15 May 2022. And this pregnancy was planned and spontaneous. And she had history of some spotting early, but there was no evidence of subchorionic hemorrhage. She has not had any bleeding since that time. Her nausea have been mild, and she had no infectious exposure. Of note, on prenatal vitamins, no other medications. On her examination, her weight, it was 112 kg, blood pressure, it was normal, pre-pregnancy body mass index 35. And laboratory investigation, her hemoglobin was stable, 145, blood group are positive with negative antibody screen. Her platelet, it was 34, and this is her usual for her life, like between 24 to 34. This is stable for her. Serology was protective. Screening for gonorrhea and chlamydia was negative. Pap smear, it was normal, and NIPT low risk. She had an ultrasound, showed that normal NT and going with her date. So we sent for her a hematology consultation, and she was seen by the hematology team as a first visit counseling with them. Her CBC, her platelet was 13 at that visit, and they discussed with her that a platelet count starting over 20 will be a little bit challenging for her during pregnancy, and maybe she will need a therapeutic trial of immunoglobulin to stabilize her platelet. And in second visit counseling, her platelet, it keep dropping. It was 11. So the plan was to start her on gamma globin with her first dose based on the ideal weight, and reassess the response for IVIG in a week. And if she does not respond, they will double the dose. So the patient should receive that IVIG, and on the day when she received it, actually she was at gestational age 17 weeks and platelet was 11. So while she was taking that IVIG, she started to have some headache, and that headache rapidly progressed over the course of the day. And then she had that visual disturbance in the left peripheral vision with nausea and vomiting. So she came for emergency department and assessed there. There is no history of fever or other infectious system, no history of infectious contact, no history of non-migraine. So at that time, they kept in mind that the new severe headache could be cerebral venous sinus thrombosis, meningitis, either drug-induced or infectious, and maybe first-time migraine for her. A couple of investigation was ordered and showed that her urine analysis, it was fine, chemistry it's fine, and her CBC showed that platelet is 34. Before that, it was 11. And CT head and MRI head was done urgent to rule out any acute intracranial abnormalities like a thrombus or bleeding, and it was negative. So she was admitted to the hospital, and the differential diagnosis, she was seen by OB high risk, and also hematology was involved in the management for the patient. And the differential was that migraine versus aseptic meningitis versus post-IVIG headache. And they said likely diagnosis was aseptic meningitis, and just that treatment was on supportive care by analgesia, antiemetic, and IV fluid. And to consider start IV empiric antibiotic if she has sign of sepsis. So the patient, by following her CBC and platelet level, we found that day of infusion, it was 11, and then elevated to 34 with a peak of 70, just over 48 hours following IVIG. And she never had fever during admission, so she never had to start on antibiotic. Because she's respond well, so the hematologist said most likely they will readmit IVIG 3 to 7 days prior to delivery to increase the platelet with different brand. And even they want to try that, but although limited data exists regarding that issue. So the patient, then she was discharged in a stable condition, and then she had her regular follow-up with the hematology and with OB high risk. In hematology follow-up, she was seen and they made a recommendation for her regarding the management of her pregnancy and also the postpartum management and postpartum management. This is what their recommendation, that the patient, once her platelet count has trended post-discharge and can be likely monitored by blood work monthly, and platelet threshold for treatment if it's just less than 30. During laboring, they recommended planned delivery rather than spontaneous delivery. And if she needs any treatment, we will consider it during the delivery. Delivery method or mode should be due to obstetric indication. And vaginal delivery will be safe with a platelet more than 30, cesarean section more than 50. And also regarding anorexia, anesthesia is often between the platelet between 70 to 100, and she needs also to be seen by anesthesia team regarding like official consultation. And also the recommendation to avoid any type of instrumental during delivery, because that increases the risk of neonatal autoimmune thrombocytopenia and risk of antibody transfer. And to consider postpartum neonatal consultation and sampling of blood cord to assess for any neonatal thrombocytopenia. And postpartum, the patient, she will be following by the hematology with the standard care of non-pregnant patient. So after discussion with the patient, she agreed to increase her IVIG from 1 gram per kg to 2 gram per kg split over 2 days. And then she was keep following in a stable condition until she reached gestation age 30 weeks plus 3 days. She had history of pre-prom and she admitted to the antenatal ward. There was a history of rupture of membrane, clear fluid, good fetal movement, no PV bleeding or any vaginal discharge. She feeling occasionally Praxine Hex after she broke her water, and otherwise she was doing well. And she had just IVIG infusion weekly as per hematology, and she had it a day before rupture of membrane. And since she had, they said there is no history of bleeding complication or reaction, and her platelet, it was range between 55 to 45, and her last IVIG dose was before that admission. On physical exam, vitally she was stable, and there is number of contraction, but it's not recording in the TOCO. And the scan shows vertex presentation, no amniotic fluid pocket, and fetal heart was normal. Vaginal exam, it was 1 to 2 cm, obvious rupture of the clear fluid. And her investigation, white blood count stable, hemoglobin stable, and her platelet, it was 14. It was 7 on the day of receiving IVIG period to the admission. So she was admitted to antenatal, and she was treated as a case of pre-prom, and or that regular workup for pre-prom was done for her during her admission to antenatal. And urgent hematology consultation was done, and they give their recommendation for the patient to give, if giving dexamethasone for lung maturity, we can pulse it with 40 milligram PO daily for 4 days for ITP dosing if there is no issue with the baby, and to continue IVIG 2 gram per kg weekly depending on her response, and other options for treatment like rituximab or TPO agent are not well studied at this stage of pregnancy and will not be used in acute phase. They recommend an ICU consultation, and they consider plasmapheresis to take off antibodies, and platelet threshold for the procedure more than 30 for vaginal delivery, 50 for cesarean section, 70 to 100 for epidural. At delivery, they recommend having at least 1 to 2 units of platelet in on call and run through the delivery or OR, and can start tranexamic acid now if there is no concern or on the neonatal issues, or few hours before the labor for preventive PPH. With a consultation with NICU, they prefer not to start tranexamic acid, as NICU said they're crossing the placenta and can clotting of fetal shunt. So we consider to give her tranexamic acid prior to delivery or cesarean section. So the patient during her staying in antenatal ward, she felt some cramping and pressure, and then she was examined and found to be fully dilated. So she was transferred to case room for delivery. 1 bag of platelet already ordered, but we never use it. Bolus of magnesium sulfate was started for neuroprotection, and she delivered smoothly, gave birth of baby girl weighing 1 gram and 1 kg and 600 gram. And baby was handed to an ICU team. Placenta was delivered. Tranexamic acid and carbotoxin was admitted and administered. Blood loss was less than 500, and just small medium episiotomy was repaired under local anesthesia. And mother and baby tolerate the labor and delivery well, and were transferred to the recovery to delivery room in good condition. And baby was sent to an ICU on CPAP with Apgar for 1 minute, not detected. 5 minutes, it was 8. Regarding the baby, she gave baby girl at 30 weeks plus 6 days, and admitted to an ICU for her prematurity and associated risk due to prematurity mainly, and not due to the maternal thrombocytopenia. And treatment in ICU was include respiratory support for surfactant for IDS, chest thoracentesis for pneumothorax, antibiotic for 48 hours, phototherapy for hyperbilirubinemia, and the patient the baby she had intraventricular hemorrhage that it was bilateral grade 2 and with ventricle dilated, and after that she has post hemorrhagic hydrocephaly. Neurosurgery was consulted and involved in that. And the baby, she was being discharged home into the community after 39 days in ICU with correct gestation at age of 36 weeks and 3 days. And by reviewing her blood platelet, it seemed that since birth, it was more than 100. It was 136, and in discharge, it was 255. So there was no concern related to the patient to have neonatal thrombocytopenia. So this is the summary of our case, and regarding my topic today, I want to talk in this round about immune thrombocytopenia purpura in pregnancy. So outlines for today: introduction, definition, differential diagnosis, overview of evaluation, monitoring blood count, when to intervene, obstetric analgesia and anesthesia, delivery, neonatal testing and outcome, and future pregnancy for the patients. By the introduction, thrombocytopenia in the pregnancy is a common and most likely represent a benign process occurring 8 to 10% for all pregnancies. Thrombocytopenia in pregnancy can be a benign process requiring no intervention at all in case like gestation thrombocytopenia, and can be rarely deadly disease that need severe and aggressive intervention. Platelet count is slightly lower in twin comparing with the singleton pregnancies. There is a mild decrease around 10% in the concentration of the platelet count occurred during all complicated pregnancy, mainly second half. The mechanism could be involved combination of hemodilution, increased platelet activation and clearance, platelet sequestration in the placenta as a normal physiological change in the pregnancy. So platelet count between 100 to 150 at any time during pregnancy, it's likely to be gestational thrombocytopenia and no need for further evaluation. Just we need to do further evaluation if we have thrombocytopenia before the pregnancy or other diagnoses cross to our mind, such as preeclampsia. Platelet count less than 100, it happened just in 1% in all complicated pregnancy. So it should be investigated for other etiology than gestational thrombocytopenia. This table is about our differential diagnosis of thrombocytopenia in pregnancy, and it can be like decreased platelet production or sometimes peripheral conception with a normal coagulation or with abnormal coagulation, and other differential physiological, and fourth one will be exogenous causes. For reason decreased platelet production, bone marrow abnormalities, miscellaneous medical condition like leukemia. If we have a peripheral consumption with normal coagulation, our differential will be ITP, antiphospholipid syndrome, HIV, SLE, or like miscellaneous medical condition, hepatitis. If peripheral conception with abnormal coagulation, cross our mind that she had hemolytic uremic syndrome, thrombotic thrombocytopenia purpura, severe pregnancy-induced hypertension HELP syndrome, acute fatty liver pregnancy, DIC. It could be physiological, just incidental, or gestation thrombocytopenia, and exogenous cause, drug-induced thrombocytopenia, allergic thrombocytopenia, or post-transfusion. And here the spectrum for our intervention. Sorry. Yep. So if you just search thrombocytopenia, no need for aggressive intervention, ITP it's middle, but if it's HELP or TTP or HUS, we need aggressive intervention. And so I will talk about thrombocytopenia introduction and pathophysiology. Idiopathic thrombocytopenia purpura is the most common autoimmune bleeding disorder in the pregnancy. It's affected 22 in 1,000 delivery, and most common in women under 40 years. And 1/3 of the patient have persistent disease resistant to the many treatment. Any autoimmune disease may increase the risk of IUGR placenta insufficiency, and ITP, it's one of the autoimmune disease. For that, during our follow-up and antenatal, we consider like regular ultrasound gross looking for any IUGR or any placenta insufficiency, beside our regular CBC checkup for the platelet count. Regarding pathophysiology, that immunoglobulin G antibodies are formed as autoimmune antibodies against the platelet surface glycoprotein. And this antibody-coated platelet are removed as they bind to receptors of macrophage within the spleen. This lead to destruction of the platelet within reticular endothelial system and lead to the thrombocytopenia. We know that its immunoglobulin G is actively transported across the placenta and has a potential to cause a fetal and neonatal thrombocytopenia, but even though only a small proportion of the baby born to mother with ITP are thrombocytopenic. Regarding symptoms and sign, usually when we see a patient in the clinic, the symptoms of sign need to be asked. It can range between mild bleeding like easy bruising, epistaxis, gum bleeding, or menorrhagia, to severe range of the bleeding, hematuria, and gastrointestinal bleeding. And usually this happens if her platelet count is less than 10. Intracranial hemorrhage is the principal cause of the death related to ITP. So regarding our patient, for that, we did for her CT, MRI, and CT and MRI head to rule out any hemorrhage or any thrombus. And physical exam for the patient, we will look specific for petechiae and ecchymosis. So regarding our evaluation for the patient, this is a recommendation for investigations for any suspected patient ITP in the pregnancy. Patient should be investigated for possible ITP if she had any history suggests of ITP, if her platelet count is less than 80. As a non-pregnant patient, ITP is still one of is diagnosed by exclusion, and we use detailed patient history, physical exam, and blood count and blood smear examination to reach diagnosis. Unfortunately, there is no gold standard test for ITP in the pregnancy, and laboratory evaluation is similar to non-pregnant patient, but we will give like a special consideration for ordering some blood tests to rule out any hypertensive disorder, microangiopathic disorder, coagulopathic disorder, hepatic disorder associated in this pregnancy, as I mentioned in the first schedule about first table about the differential diagnosis of thrombocytopenia in the pregnancy. And the recommended test should be based on the clinical feature of the patient. So if we want to order like a blood smear, it's to rule out the presence of our red blood cell fragmentation seen with microangiopathic hemolysis or preeclampsia. Reticulocyte count can be used to identify cause of anemia because sometimes severe vitamin B12 and folate deficiency can lead to thrombocytopenia. Coagulation screening in the form of PTT, fibrinogen, and D-dimer may be helpful in excluding chronic DIC or other coagulopathy. And coagulation with the liver function and combined can suggest alternative diagnosis if we suspect we have a HELLP syndrome or we have or infection or DIC. And there is also additional laboratory testing will be guided by the patient history of thrombocytopenia, bleeding, thrombosis, or pregnancy loss, or other laboratory or clinical finding for the patient. Like thyroid function test, because they found that ITP patients, sometimes they had like a clinical hypothyroidism in 8 to 14% of the patient. But so for that, thyroid function can be considered. And regarding anti-nuclear antibody and antiphospholipid antibodies, they consider it antiphospholipid antibodies like anticardiolipin antibodies and local anticoagulant because they found up to 30% of the adult ITP patient with this antibody, they will not respond well to ITP treatment. But routine testing is not recommended in the absence of the symptoms of antiphospholipid syndromes like venous thrombosis, arterial thrombosis, or history of recurrent pregnancy loss or fetal loss. And regarding anti-nuclear antibodies, because they found it will be positive in 9% of children with ITP and 33% with the adult of ITP. So may it's considered like a predictor of chronicity, but testing can be considered before the splenectomy because the patient, she will be high risk of thrombosis. Last thing, testing for TPO level, thrombocytopenia level are generally not recommended because it's usually if in non-pregnant women, they order it because just to differentiate between ITP or thrombocytopenia result from bone marrow failure because it will be high. Well, but TPO in the pregnancy, it's usually elevated, so it's not recommended. And 90% of the patient with the ITP had increased level of platelet-associated Ig, hemoglobin G. So even though antiplatelet antibody testing is not recommended and does not predict the course of maternal or neonatal thrombocytopenia, and that does differentiate between ITP from gestational thrombocytopenia. Bone marrow examination, it's not recommended. So regarding platelet count monitoring, usually if we have severe ill patient with other association or reason for thrombocytopenia, the patient, she need to be tested for a Q4 to 6 hours. If the patient just hospitalized due to a maternal illness daily, and if the reason it just not hospitalization for hyperemesis or asthma, even if the patient is stable, she doesn't need for platelet count monitor. And as general, mild to moderate thrombocytopenia once per trimester or once per month, and also it depends from the patient absolute platelet count and how her trending of the platelet during pregnancy, and every other week in the third pregnancy, and weekly after 36 to plan for possible need of treatment near delivery, and for sure in the day of delivery. Routine obstetric management, it's appropriate in the platelet more than 100. So any patient platelet more than 100, no need, she will treat like any normal pregnant. This is just a clinical feature of management for any disorder associated less than 80 for the platelet. I will skip it because of the time. So when to intervene? Recommendation for management of ITP in the pregnancy are primarily based on the clinical experience and expert because there are still few RCT for that. They found that a stable platelet count between 20 to 30 is safe during most of the pregnancy, unless the patient she has a symptoms of the bleeding or there is a procedure is planning, and otherwise just management will be managed by observation. Late in the third trimester, the platelet count need to be at least 50 and required to preparation for delivery, which may be achieved by scheduling delivery for the patient. And the thrombocytopenia may persist in postpartum or may get worse even postpartum. Further follow-up postpartum need to be done for the patient regarding her platelet count. 54% of the cases with ITP worse after pregnancy and occurred in splenectomized women, and patient with previous splenectomy should be closely monitored, like our patient. And anecdotal data suggests that breastfeeding may propitiate maternal postpartum thrombocytopenia. And platelet less than 10 at any time. Treatment recommendation when we need to start treatment for our patient. If the platelet is less than 10 at any time of the pregnancy, if the platelet between 10 to 30 during the second and third trimester, or if she had any bleeding, we need to start treatment. We talk about platelet transfusion. Platelet transfusion, it's discouraged because infused platelets are quickly destroyed by the same mechanism that destroy the patient on platelet. Unnecessary transfusion may stimulate more autoantibody formation and worsen the maternal thrombocytopenia. So just a specific indication that we can start platelet transfusion for ITP patient if we have severe or life-threatening bleeding before cesarean delivery, if their platelet is less than 10, before vaginal delivery with bleeding and her platelet less than 10. When giving during surgery, the platelet may be transfused at the time of skin incision and to aid with the surgical hemostasis. So I will talk about treatment for the patient with the ITP. We will start by the initial treatment. The first choice for initial treatment is a corticosteroid. It's low-dose corticosteroid at the first-line therapy, and maybe less effective in the pregnancy, as a 40% of the patient achieving an increase in the platelet count with this treatment. And the mechanism for that is because corticosteroid, it increases platelet production, decrease production of antiplatelet antibodies and platelet-associated IgG, decrease clearance of antibody-coated platelet by reticuloendothelial system, and decrease capillary fragility. But we keep in mind that corticosteroids have some adverse effects like hypertension, hyperglycemia, osteoporosis, weight gain, psychosis, and possible small risk of causing oral cleft when administered in the first trimester pregnancy, and especially with the DEXA. Our choice of corticosteroid, prednisone, it's 21 milligram kg per day for 2 weeks, following gradual tapping. And usual initial response between 4 to 14 days, and the peak within week to 28 days. And also there's an option for high dose dexamethasone. It's 40 milligram per day for 4 days, and initial response within 2 days to 2 weeks, and peak within 4 days to 28 days. And even there is no difference in the platelet count and response within prednisone or dexamethasone, but showed that dexamethasone lead to faster response without additional toxicity. This is a relevant contraindication to high-dose corticosteroid therapy if the patient has insulin-dependent diabetes, uncontrolled diabetes, psychiatric disorder, or active infection. After delivery, the platelet count should be monitored. Corticosteroids should be tapered slowly to avoid rapid decrease in the platelet count and to ensure the mother mental state is not affected. Second option for the treatment is IV immunoglobulin, and this may increase the platelet count faster than corticosteroid within 1 to 2 days, and substantial elevation of the platelet in 75 to 80% of the patient. So 70% of the patient, the platelet count return to pre-treatment level within months. So the patient, she need like a maintenance therapy to be used to keep her platelet level in that level we needed, or re-administration maybe time 5 to 8 days before the planned delivery. The mechanism for IVIG, it's depression, causes depression for antiplatelet antibody production, interfere with antibody and attachment to the platelet, inhibit macrophage receptor mediated immune complex clearance, blockage of FC receptor in the reticuloendothelial system. Adverse effect, flu-like symptoms, headache, chills, nausea, flushing, like happening in our patient when she receive IVIG, and also can have a liver dysfunction, transient neutropenia, and rarely autoimmune hemolytic anemia and anaphylaxis. Third option, it's an anti-D. Usually give it in Rh positive, non-splenectomized women, appear to be well tolerated by mother and fetus, effective in second and third trimester based on the result of small pilot study. Monitoring is required for neonatal jaundice and anemia. The dose 75 microgram kg of maternal weight. So if we start that initial treatment and the patient, she is not responding and her platelet get decreasing, we have other option in failing initial treatment. The first option, the first thing that we need to do a combination therapy. So indication for combination initial therapy agent or adding other agent if the patient refractory to initial single therapy, if the patient their platelet count fell despite continuous therapy. We have an option to give her high dose methylprednisolone with IVIG or azathioprine. It seems that cyclosporine and azathioprine are safely used in the pregnant patient with orthopedic organ transplant and may be effective in patients with ITP refractory to other therapies. It could take weeks to increase the platelet count. Other combination therapy, rituximab can be considered in pregnancy for very severe case. It is a monoclonal antibody medication that treat different type of blood cancer, and it help in those patients with cancer to better fighting the cancer. But other immunosuppressive agents, including vincal colloid and MMF, should be avoided during pregnancy because associated of teratogenicity. Other option for that failing, we can use thrombopoietin receptor agonist or recombinant human thrombopoietin, and this is stimulate dimer FC peptide fusion protein to increase the platelet production through the activation of thrombopoietin receptor. So these agents may be considered in exceptional circumstances only in the third trimester near delivery, although tolerability and toxic effect on the fetus have not been evaluated. The option of rimoplostin and electropeg may cross the placenta and could cause potential harm for the fetus. But romiplostin may be preferred giving because it's off of target effect like of hepatic toxicity and uninsulating and limited safety database. Regarding recombinant human thrombopoietin, it's likely to cross the placenta, effective in increasing platelet count in the pregnant who were unresponsive to steroid without untoward effect of the fetus, just only available in China. Other option, we have splenectomy. It's required in very rare case. It's the best performed second trimester and laparoscopy is possible, and to consider vaccination according to national guidelines. Venous thromboembolism, we need to keep it in the mind to give it to the patient, because the patient, in addition to prothrombotic state of the pregnancy, some patients, they are high risk factor for thrombosis, they need it. So any platelet count more than 50 is generally recommended to start venous thromboembolism prophylaxis. This is the recommendation for the treatment of maternal ITP. Usually initial treatment will start by oral steroid or IVIG. IV anti-D in Rh positive non-splenectomized women appear to well tolerate and effective based on the result from small pilot study. Might potentially cause maternal fetal hemolysis, so keep it in our mind. IVIG can provide a rapid but often very transient increase in the platelet count and can be used to urgently increase platelet count during bleeding or for delivery. Combination therapy, prednisone, IVIG, or IV antibody may elect a response to an patient refractory to single agent alone. High dose methylprednisone with IVIG or azathioprine suggests for patient refractory to oral corticosteroid or IVIG. Rituximab can be considered in pregnancy for very, very severe case, and keep in mind that potential prenatal and neonatal immunosuppression and subsequent infection are potential complications and require monitoring. TPORA may be considered in late pregnancy when other treatments are failed, but published information is limited. In the rare instance when the splenectomy is required, should be performed in second trimester and by laparoscopy. Fecal colloid and the nasal immunosuppressant not recommended and should be avoided during pregnancy. I will skip this slide. So we'll talk about obstetric analgesia and anesthesia for ITP patient. The recommendation was that any platelet count more than 70, in the absence of other hemostatic abnormalities, regional anesthesia can be safely performed. NSAID should be avoided for postpartum or postoperative analgesia in women platelet less than 70, or because it increases the hemorrhagic risk. Platelet count more than 50 should be obtained for the delivery. All women, despite having ITP, who are at increased risk for thromboembolism, should receive appropriate prophylaxis for venous thromboembolism. The mother with the rapidly filling platelet count should be observed more closely than with low but stable level. So if the patient reaches the delivery, the main maternal risk is the hemorrhage during the childbirth. Maternal treatment for thrombocytopenia from ITP may be more intensive as the patient approaches the term, because we in anticipation for potential bleeding, possible surgery for cesarean section, and need for regional anesthesia. Platelet count more than 50 should be sufficient to avoid bleeding complication during childbirth, regardless the route of delivery. Neither maternal platelet count or maternal serum antiplatelet are reliable to predict the severity of the fetal thrombocytopenia. Neither fetal blood sampling nor cesarean section has been shown to be beneficial in avoid fetal neonatal bleeding complication associated with maternal ITP. Cesarean delivery should be reserved for the usual obstetric indication. Postpartum hemorrhage is common in the woman who is untreated unrelated to the mode of delivery, so we anticipate PPH and be ready for that. And like in our patient, we give her tranexamic acid and or the measurement to control PPH. Regarding the recommendation for management of delivery a newborn infant, that said chordocentesis and fetus cord blood sampling should be avoided in the management of the fetus and neonate of the mother with the ITP in the pregnancy. Neonatal immune thrombocytopenia should be excluded by parental testing if the neonatal present with a severe thrombocytopenia less than 30. Previous splenectomy has been associated with the worsening of maternal ITP in the pregnancy, high risk for neonatal thrombocytopenic, like in our patient. She had a worsening of maternal ITP in the pregnancy, but her baby, she was fine, no neonatal thrombocytopenia. The mode of delivery should be determined by the obstetric indication, not by anticipation of the neonatal platelet count. Procedure during labor may be associated with increased hemorrhagic risk of the fetus, should be avoided, like use of fetus scalp electrode, fetal blood sampling, venous delivery, and rotational forceps. Next, we talk about neonatal outcome and testing. That no strong correlation between maternal platelet count and neonatal platelet count in ITP. Risk factor for neonatal thrombocytopenia include if the patient she had previous history of neonatal thrombocytopenia, prior splenectomy, like in our patient, severe thrombocytopenia less than 50 at the same point during pregnancy, at any point during pregnancy. There is no evidence that ITP therapy for the mother raised the fetal platelet count. Neonatal testing is performed after delivery, typically by cord blood platelet count using clean venopuncture of the cord vessel, not draining blood from the cord. Platelet count testing by scalp blood sampling or chordocentesis not recommended, as it associated with adverse event and had been not been to improve the outcome. So the recommendation for management of neonate born to woman with ITP, umbilical cord platelet count should be obtained at the time of delivery or as soon as possible. Repeat the platelet count as needed, depending on the platelet level of the baby, trend in the count, respond to the treatment if they started or needed. Cord platelet less than 100, repeat the platelet count daily until it is stable. In severe thrombocytopenia, continue for 1 week in the breastfeed infant. Consider pausing breastfeeding for a few days to see whether platelet count is increased. Women who had splenectomy may have thrombocytopenic newborn, even if their platelet during pregnancy was normal. The only current available predictor for whether the baby is thrombocytopenic if the previous sibling have thrombocytopenia at birth. Regarding future pregnancy or the women of childbearing capacity with ITP should be considered that ITP is the most, it's almost never a contraindication for pregnancy. Management of the woman with ITP wishing to become pregnant should perform in joint with obstetrician experience on high-risk pregnancy and hematologist knowledgeable in ITP. And author experience serious bleeding complication, antepartum, postpartum are extremely rare. So take home message, the outcome of pregnancy, pregnant women with ITP is generally good. Maternal platelet count had no predictive value for neonatal thrombocytopenia. Women who had splenectomy, like in our case, may have more worsening of maternal ITP in the pregnancy and may have thrombocytopenic newborn, even if their platelet count is normal. Corticosteroid and IVIG are not just our weapons against aggressive ITP in the pregnancy. We have a lot of options, and we taking care for the patient with our colleague in the hematologist. This is my reference, and thank you. And at the end of the round, I said, again, special thanks to Dr. Hsia, hematology consultant, and Dr. Eastabrook for preparing, for helping me in preparing this round and providing me by, or I needed to have this round. Thank you, everybody, for attending. And if there is any question, you are most welcome.
Well, thanks so much for that, Sabrine. It's Iris. Nice to meet you virtually, and all our colleagues in obstetrics gynecology. Thanks so much. I know we have lots of mutual patients together that we've had through the years, and I don't think any case of ITP during pregnancy ever gets easier. I think every patient we have is rather unique and don't never follow a textbook, I guess. And so we certainly have our cases with ITP during pregnancy who do wonderful and never need treatment. Like you said, majority of patients with ITP during pregnancy, we just monitor, and their platelets might be somewhat low, but they're asymptomatic, and they do fine with no issues, no peripartum or postpartum issues whatsoever. And then of course we've always had those really challenging ones like the one you've described. And fortunately, she and her baby are doing well at home. But postpartum, I can tell you that her ITP, and perhaps it's because she's still breastfeeding, is she's still struggling with her ITP, and it continues to relapse. So she's still needing intermittent IVIG, and she's not keen on other types of treatments at the moment. You know, when looking at future pregnancies, I think it is a really good discussion to have with women and their families about future pregnancies. And I wish we could have predictive factors of who is going to do worse or not, but we don't know. And so, like you mentioned, a child with a previous thrombocytopenia may be somewhat predictive of a future child with thrombocytopenia and similar platelet counts. But the mother, I don't know, like in all of this time where we have women and how to counsel them, there are women with ITP where their ITP may be better the second time, or it may be worse. I don't seem to see a pattern. There's no sort of rhyme or reason for it, and so very challenging. But at least in a way, it's better than neonatal alloimmune thrombocytopenia or NATE, in that in NATE patients, and knock on wood, we haven't had one recently where for these women, we have them on weekly IVIG from week 12 or week 20, depending on their previous experience with a neonatal thrombocytopenic neonate. And we know for those individuals, by anticipation, the next pregnancy will lead to a worse outcome with a worse thrombocytopenia in the neonate, and perhaps worsening intracranial hemorrhage and so forth. So at least in ITP, the outcome in the child might be somewhat similar. So, but otherwise, very difficult to predict. Sorry, I think there might be a question for you.
Oh, yeah, hi, it's Janine. I was actually rounding on this patient that week, and that was a great talk, Sabrine. I guess just a couple comments. Just first one to clarify the tranexamic acid. So I was actually rounding on her, so I did kind of a frame clinic consult with her, and she was an emerge nurse, so she had a really good understanding of medicine and everything. So we kind of got lucky with her as a patient and the timing of delivery with response to her IVIG. But I was planning to actually try to arrange a multidisciplinary meeting to discuss the therapeutic recommendations. I had talked to her about tranexamic acid because she wasn't actively bleeding. I told her, you know, it's not really well studied in pregnancy, and, you know, there potentially theoretically could be implications to placental vasculature, and we didn't really know, but if she started to actively bleed, then we could start it, or around the time of delivery. There's about 200 cases of kind of a pilot study of giving TXA to women with an antepartum hemorrhage, and it's reduced the blood loss and improved outcome. So there's a bigger study ongoing for that. But, you know, if you just kind of look at initial studies, all the TXA safety data comes from giving it just before cesarean section, which really doesn't have much fetal exposure. So I don't think that can be translated for long-term use in the pregnancy. So that was kind of our talk about TXA. But if she started bleeding, then the benefit would probably be there. And then with respect to the steroids, you know, we had the SNACS trial talk about long-term outcome on baby, and the dexamethasone was such a high dose, and given that it would cross the placenta and potential implications to the baby and her lack of response previously to steroids, we had kind of talked about not starting it. And then we got lucky at the time with the IVIG, but if she didn't respond, I was going to reach out and just say, what other therapeutics could we try? But then she went into labor. So I'm not sure what the next line would have been, just because I guess from our point of view, there might be adverse effects on the baby of the high dose steroids.
I'm sorry. Did you want me to answer, or did you want Sabrina?
Yeah, I don't know, like what would have been the next step, I guess. That was my question at the time.
That's a really good question, Janine. I wish I had an answer for you. I mean, in the so with our patient, she does have potential options, like Sabrina outlined. Things like azathioprine have been used safely in pregnancy. What we find is that, unfortunately, with azathioprine, it takes a long time, weeks and sometimes even months, for it to work. And so even though it's a potential option, it's practically not very useful in that setting. Rituximab has been used to some success, and it can be safely used in pregnancy, but also it gives you a faster response within 4 to 8 weeks. But again, you're talking about somebody who's in I think her 3rd trimester by that time in discussion. So it may not have been so very effective either within the short time span. The best outcomes would be, and again, they're just case series like Sabrina outlined, which were the TPO receptor agonists, like romiflostim or eltrombopag, but those are not funded, unfortunately. And so she would have been in a position that she could have maybe paid out of pocket, or if she had private insurance to cover it, ideally that would be the best outcomes. And so there's only case series of those. The largest was published in Blood recently, that recently 2019, I guess, that showed for 15 patients, 17 pregnancy outcomes, that women safely used the TPO receptor agonist, and the outcomes for the baby were also very positive. So if we had to beg, borrow, and steal, that would be the best route for this patient, apart from convincing her that a combination of IVIG and steroids would be the next line of therapy. And with respect to steroids, like you mentioned or alluded to, we completely agree. With dexamethasone being dosed high doses and crossing the placenta, it's not our first choice. Prednisone would be our first corticosteroid choice if we can, and using the combination of prednisone and IVIG would probably be our 3rd line. So usually I think most people feel comfortable with IVIG as kind of 1st line, then the prednisone as 2nd line, and then combination of IVIG and prednisone as 2nd line, or increasing the dose of IVIG from 1 gram per kilogram to about 2 grams per kilogram. And then just a quick note on the dosing as well. I don't know if you got into, I don't think you got into it, Sabrina, which is the dosing is 1 milligram per kilogram, but it's dosed on a ideal body weight pre-pregnancy. So it's not their current weight, it's their pre-pregnancy ideal body weight.
Okay, thank you.
Hi, it's Genevieve. I had a question. So the patient had been reticent to try steroids again because she hadn't had a terrific response to it, but more importantly, she had a very significant side effect profile with it in her use. But I noted that after she received her betamethasone for fetal lung maturation, she actually achieved the highest platelet count that she had in the entire pregnancy of 70, which was very fortunate because it happened to be just prior to her delivery. So, I mean, obviously, betamethasone isn't a treatment of choice for ITP, but she certainly had an acute response to it. So I don't know if that's something that has been seen previously with like a single dose of, because the betamethasone dose we give is quite large, it's 12 milligrams. So I was just wondering if that was related or whether it was just simply coincidental.
That's a good question, Genevieve. Nice to meet you as well, virtually. Yeah, it's very possible that it could have contributed to it in pregnancy as well. IV methylprednisolone, IV hydrocortisone have been used to some success, even with doses of like once a day for 3 days. So it's very possible it contributed and in combination with the IVIG as well. So the two may have synergistic effects. But you're right. I mean, I've still talked to her now about corticosteroids, and she's very reluctant to try corticosteroids.
Yeah, I think in the case of this patient, I mean, this is a disease that she's been living with for most of her life, and she sort of perceives that, you know, as long as she's not having any symptoms, regardless of the platelet count, that she's doing fine. And so she was really a bit thrown for a loop about how aggressive we all seemed in terms of treatment, because of the risk, obviously, of bleeding with the pregnancy.
Yeah, that's right, and it's hard to, even with her emergency nursing background. I think, you know, she knows some of the risks associated with it, but she is reluctant to undergo corticosteroids for the side effects and perceived side effects of some of the other treatments as well. So it is hard, but you know, for a lot of potential patients, there is that much higher risk of severe bleeding outcomes, as Sabrine kind of outlined. With platelets less than 10, that risk starts to go up, and potentially could go up exponentially, whether they're pregnancy or not. The risk of bleeding goes up exponentially with the platelet count less than 10. Well, thanks so much, Sabrine, again for that wonderful summary and talk. And, thanks for having me, and nice meeting you all. So
Thank you so much, Lily, for helping me, and everything was useful that we contact you. And thank you for your adding in that round. It was so valuable and informative. Thank you.
take care.
Okay.
Bye.
Thank you, Dr. Hsia, and thank you, Sabrine.
Okay. Thank you. Okay. Take care and have a great day today. Okay. Bye.
You too. Bye.